Okay, so let's put this discussion at the end. I propose that we have now the presentation of Professor Zileli. I think he's talking about the microdiscectomy with the use of the tubular access systems. So maybe after this presentation, we may come back to this discussion we just had. It's a very interesting discussion. And as usual, there are different opinions because people have different experience. And as we know, medicine and specifically surgery is not an exact science. So it has a lot to do with experience. And there are always people, both sides are right, you know, because they have a different experience. So let's see what Mehmet has to tell us in his presentation, and then we will continue the discussion. Please.
Okay, thank you a lot. Actually, it is our ongoing, continuing discussion with Dr. Yunus Aydın for many years. And so then many audience we are collecting with this triple discussers. Actually, if you look at the minimally invasive discectomies, there are mainly three techniques. One is the microdiscectomy. Dr. Fahir Özer has described that. Transforaminal endoscopic discectomy and interlaminar endoscopic discectomies. I will try to give some details later before the end of my slides. This microendoscopic discectomy technique has been first described by Foley and Smith in 1996. The main advantage was they were using the muscle splitting instead of the muscle damaging, less damaging. So then the main advantages with the conventional microdiscectomy, you have to strap the muscle laterally. However, in this instance, you then place a tube by dilation of the muscle. So then less injury is possible for the muscles. At the beginning, they have used endoscopy, but they then switched to microscope. Actually, this is also the practice of Dr. Fester that Dr. Yunus Aydın has mentioned before. He's also using nowadays the microscope with tubes. The main parts are this. This is a table-mounted flexible retractor, and this is a tube. You can either use endoscope by looking at the C-arm fluoro and endoscope monitor, or you can look inside the tube from a microscope. But one small point, small hint that to make it so with the microscope, the illumination of the view of the microscope must be very small. If you cannot do it, then the glaring coming from the instruments, the tube itself and from the instruments may pretend you to see the structures well. This is the optic parts. These are the instruments. These are the dilators and introducers. Instrument sets are almost same as we are familiar with microdiscectomy, but they are black, non-glaring, and ceramic-coated instruments. You start with a key wire introduction, then dilators, and place a different type of tubes. And that tube is connected with a flexible arm to a table-mounted part. This is the endoscope with a 25-degree angled image. So then you can see in the tip some other parts of the tube end. But one point is that it is different because we don't use a water irrigation system with such endoscope. The the tip of the tube may get dirty with the blood, so then you need to remove it and then clean it again. This is the order. This is the system I was using at the beginning, and the guide wire placement, the later insertion, tubular retractor administration, then endoscope insertion. These are the steps. Then at the end, you see the on one side the lamina edge, and you strap the ligaments from the lamina, and you can enter the ligaments and you remove a part of the ligament. I don't think that ligamentum flavum preservation is a big deal in those surgeries. If you don't leave too much blood on the background, you will get very small amount of fibrosis. And I believe the main reason of the fibrosis is the instability, as Dr. Fire has said before. Sometimes if you need to look at two consecutive levels, you can angle your tube in different angulations, and then you can look two levels with one incision only. Yes. Then this is the end. The muscles are reapproximated at the end. I will show you in my videos. And current tubes in the market are matrix tube that I am using from Medtronic. EasyGo system is from Storz. Destando system is also from Storz. There are also some other local companies producing such tubes. That tube system is very easy to handle, and learning time is shorter. Then you can even apply it for decompression of the spine stenosis in multiple levels. You can come from one unilateral approach, and bilateral decompressions are possible. You can see here. And you can also apply it for far lateral lumbar disc herniation. One example. If you look at the transforaminal endoscopy and interlaminar endoscopy, actually interlaminar endoscopy has more indications than transforaminal, and L5-S1 is difficult for transforaminal. However, interlaminar is easier for L5-S1. One note that you can also make an interlaminar endoscopy using a full endoscopic system with water irrigation. To do that, you need a 7mm diameter tube. Storz and Wolf companies have this. This was introduced by Dr. Rutten from Germany. But the difficulty is that since you don't have a retractor here, you must use your tube, your introducer, by turning your tube for retraction of the nerve root. These are the steps. So by turning your angled tube tip, you must retract the nerve root and see the disc herniation. These are the steps. If there is some stenosis, there are also some drill devices applicable from those 7mm diameter water irrigating systems, but these are specially designed, and in stenosis cases, drilling is harder. There is a steep learning curve, and baseline instruments are expensive. In general saying, tube-guided surgery is an ambulatory surgery, very short hospital stay. You can do it with spinal anesthesia or epidural anesthesia, less tissue damage, no superior dissection is necessary, smaller incisions are possible. But the fact is, it is not superior to microdiscectomy in terms of clinical results. However, hospital stay and return to work were found shorter in many different series, comparative series. In conclusion, tube-guided discectomy may be applied in all forms of spinal stenosis. Small modifications of conventional instruments, baseline equipment are inexpensive, may be applied with endoscope or microscope, and learning time is shorter. Now I will show you some videos and some presentations. This case is a 55 years old male, acute onset leg pain for 1 week. Straight leg raising test was positive. Of this case, screen sharing, no. Now, I think I must start from the, yes. Do you see the video? Yes, this is that case, 4-5 extruded disc herniation. I removed the ligamentum flavum. But I tried to preserve the fat tissue. If necessary, I coagulate the vessels. And whenever I see the, if it is a free fragment, it's easier. Now it's a free fragment. Then at the end, when we remove the tube, you will see that the muscles are reapproximated there. And we place some stitches. Sorry. I will show you Mehdi. Who is Mehdi? Mehdi is screen sharing. This is another case. A 20 years old male patient, L5S1 disc herniation. Is it?
Hocam şu an oldu.
Şimdi geldi.
Şu anda görülüyor hocam ekran.
Evet. Yes. Okay. This is, yes. We can go faster. Yes. I did a small incision on the ligament, and then a retraction of the ligament with the using a curette. I removed the lateral part of the ligament, but I tried to protect the fat tissue. This is the root, and just under that, the protrusion. Yeah, make a small incision in the annulus. At the end, I always irrigate the level first with saline solution, then with some antibiotics. Then this is the end. And we remove it. Again, 1.5 centimeter incision is enough for such a
Intervention, yes.
Then I have one more.
Okay.
Far lateral disc herniation of a male patient. Here you can see L3-4 level. This is the disc herniation. And we can enter here with a paramedian 4 centimeter lateral to midline incision. Is it all?
Şu an görünüyor hocam.
Yes. In this case, we have to open the intertransverse ligament. After opening that, a very thick fat tissue can be seen. And after dissection of that fat tissue, you can see the root, traversing root. And if you retract that, you can see the protrusion. This is the protruded segment. And I did again a incision there. Yes, this is the fragment coming from the level. I irrigated this space again and some antibiotics, rifampicin, and place a sponge and remove the tube. Muscles are reapproximating again. Yes, this is all I want to present you. I can unshare the screen. Okay, thank you. Thank you for listening to me.
Thank you very much. So are there any questions for this specific presentation of Professor Zileli?
There is one question Özkan Ateş is asking. I think this system is a retractor system. What are you thinking? Yes, this is a retractor system. Better than the retractors used for microdiscectomy. But I admit that the outcomes are similar. I didn't want to say that outcomes are very different. But with this technique, the postoperative pain are less, incision scar is less, and return to work is shorter. There are many studies describing that. But in 1 year follow-up, VAS scores or Oswestry Disability Index or other outcome scores are almost same. With microdiscectomy, even with open discectomy.